Welcome back to the Nursing Ministry channel, a platform where we discuss all matters nursing as a profession and also as a ministry. For those who are first-time viewers, my name is Ludia Osita and I am a registered nurse. And for the returning viewers, thank you. Thank you. Now, this is Nursing Hierarchy Part 2. We discussed Part 1 last week and where I had introduced you to the various cadres that make up this hierarchy. And for those who may not understand or where we are starting off this week, I'd encourage you to kindly go and watch the previous episode, which we aired last week, to be able to understand, then come and join us for a better understanding. Now, in our previous episode, we had discussed the nursing hierarchy and related it to the book of Genesis chapter 1. We saw that God has created us in his own image and likeness. And by this, he had created the entire creation that we see today in bits. He did portion by portion, day after day. He did not just say, let there be creation and the whole world appeared, but he took time and bit by bit until the sixth day when he had created everything so that it was very good, blessed them and told them to be fruitful and multiply. Now, we who have been created in his own image as nurses, we also have this hierarchy. We have the certified nurse assistant as the major nurse, nurses, as the most basic of nurses. The certified nurse assistant, also called the CNA, followed by the licensed practical nurse, as he had mentioned, also known as the LPNs. Above them is the registered nurse, also called the RN. Above them is the charge nurse, also called the CN. So I will not go ahead and summarize or try to review what we discussed last week. For the benefit of time, kindly watch our previous videos, because this week we are taking off from the advanced practice registered nurse, who is above the charge nurse, followed by the director of nursing, and finally the chief nursing officer. And as I had promised, it is in this episode that we are going to look at how you can use the CNA in you, the LPN in you, the RN in you, the charge nurse in you, the APRN in you, the DON and the CNO in you to serve your family members, to serve the community at large. So stay tuned and let's work together. Now, after the charge nurse, we have the advanced practice registered nurse. You may say, who are these? Like I've mentioned, we are dealing with nurses. So advanced practice registered nurses are also nurses, registered nurses. They cannot be LPNs. They cannot be CNAs. They must be registered nurses who have some years of expertise, 6, 10, whatever many years of expertise. And after the years of expertise, then they go ahead and train further. Training further to get certification. They train for whatever long their training session lasts. Then they do a national examination. Once they qualify, they are given a certificate to practice as advanced practice registered nurses. So these advanced practice registered nurses, other than just being RN, they must have qualified as with a Master's of Science in Nursing or Doctor of Nursing Practice, what we call DNP. Master of Science in Nursing or a Doctor of Nursing Practice, DNP. Now, the Doctor of Nursing Practice, I would relate it to what you call PhD. So they must have a master's or a PhD in nursing. That is the level of education they must have. Of course, they are still registered nurses, only that they have the master's and they have the doctorate, but they are still registered nurses with years of experience who have acquired this education. Then, of course, they take the certification examination. Once licensed, given the certificate, now they can go ahead and practice as APRNs. So what is this practice? In a broad understanding of APRNs, picture a doctor, a physician, a medical doctor, what a doctor does, only that they have a limitation. That is what APRNs are in a layman's language. They are doctors, but not really doctors. They are not qualified to do everything a doctor should do, but they have an aspect of what a medical doctor does. What are these things that the doctor does? When a doctor sees the patient or the client, the first thing they do is an assessment. You show up, you're not feeling well, they will assess you. So they do a medical history, they take a medical history, and by that I mean they may ask you questions. How do you feel? Where was the last place you visited? Have you been to the eastern part of the country or the central part of the country? Because maybe they know malaria is prevalent in that area. When was it? Have you had any vomiting apart from the fever you're complaining about? How was the vomiting? Was it projectile or what color was the vomit? That is what medical history entails, just gathering information. Once they gather information, they also do their own assessment. They may take a thermometer, check how high your fever is. They may ask you to lay down, check your lymph nodes. Is it swollen? Is there pain in your body? That is a medical examination. So objective and subjective. And then after that, they may end up writing down that they need you to take some tests. By that, they may tell you to go to the laboratory, get your blood drawn so that they can find out how's your hemoglobin, your level, blood cells, how are your electrolytes, how is your liver functioning. They may write down that they want to see that, or radiological examination. By this, I mean they may want to see a scan or an ultrasound or an X-ray. Those are diagnostic tests. Once they get these results back, they go ahead and put together their assessment together with this diagnostic test and interpret what your medical diagnosis could be so that they can come up with a conclusion and say, with this fever, with this liver function test results, looking at the fact that they are having joint pain, and this and that and the other, this could be malaria. So they come up with a medical diagnosis and decide it is malaria. Then after that, they go ahead and prescribe a treatment. So that is where they may write a medical prescription, go ahead to the pharmacy. You need to buy chloroquine, you need to buy Fancida, you need to buy whatever medication that may treat you for malaria. Together with that, because of the fever, add paracetamol, So they prescribe the medications they need you to take. Then they give you verbal prescription of what you need to do. Go ahead and drink plenty of fluids, do this and that, rest. That is just in a snapshot of what medical doctors do. Now, back to the advanced practice registered nurse. Like I've said, they are like medical doctors, only that their training is limited. They can go so far and not do everything a doctor does. That is why they go ahead and do this training, so that they know what their limit is. What is it that they can do and not do? So I hope we've understood that part. Now, these advanced practice registered nurses are categorized into 4 major groups. Yes, they're advanced practice registered nurse, but they're in 4 subcategories. So you may see an advanced practice registered nurse called a certified nurse midwife. That is one of them, one subcategory of these APRNs. Another subcategory of the APRNs is a certified registered nurse anesthetist. We call them CRNAs. CRNA, certified registered nurse anesthetist. The third subcategory are the clinical nurse specialists, CNS. And finally, the 4th subcategory are the nurse practitioners. Let's have a quick review of each and every one of them. Now, the certified nurse midwife, the CNMs, like I've said, they are APRNs. It is just a subcategory. I've already described what these APRNs do. They act like doctors, or let me say primary providers. Primary providers, doctors, I may interchange the words. So they are like primary providers, only that they don't do everything a doctor does. Now, when you see them in the facility, because they can work in any setting, be it the hospital, sometimes they are seen in clinics, outpatient centers, long-term care facilities, whichever setting they may be at, these certified nurse midwives really are concentrating on the gynecological aspect. But it ranges on the lifespan from puberty to menopause. So you clearly understand this is more for the women, from puberty to menopause. So they may attend to those who are in the puberty stage, the young adults, all the way to those who are in menopause. So they work with the reproductive health. This is the part whereby they may advise based on things like, what do you call this? My goodness. Birth controls. They may advise on birth controls. They may advise on STDs, all that. But mainly, they focus on from puberty to menopause and reproductive health. And then they also deal with prenatal issues for the pregnant women before giving birth, those prenatal tests that you do, the prenatal visits. They advise the pregnant mother, they prescribe, because now they're acting as doctors really. They're registered nurses with their masters, but they're acting like doctors. They have that certification. So they may prescribe because they have assessed this pregnant woman. They've assessed the baby in her womb, the fetus in her womb. They have checked the heartbeat of the fetus. I'm talking to you and I, so that I don't want to use very big terms. So they've assessed that, they've done physical exam on this pregnant woman. Then intrapartum during birth, they are able to also help with the delivery of the baby. Everything that a gynecologist, who is a doctor that does this, now they are able to do it, prescribing medication and taking care of this pregnant woman during birth, helping in the delivery of the baby. Once the baby is born, now you have two patients, the mother and the baby. So caring for the mother, caring for the newborn until probably a few weeks before releasing them. So we've seen these certified nurse midwives work with their patient. Before they're even pregnant, they can work with the female patient during the pregnancy, during childbirth, labor and delivery, and then after the baby is born to stabilize them. That is a certified nurse midwife in a snapshot. First subcategory of an advanced practice registered nurse. The second subcategory is what we call the certified registered nurse anesthetist. You may say, what is this anesthetist? Now, if you've been to the dentist and you've been given this very painful injection in your gums until your mouth feels swollen and numb, the person who gave you that injection could be an anesthetist. Although sometimes it's the dentist himself, because they're trained to do that. But just to give you a better understanding, or if you've never been to a dentist, you've been to the surgery. I'm going to explain better. During surgery, we have what we call the anesthetist. Anesthetist. ANESTHESTIST. Anesthetist. That is the person that gives an anesthetic. Now, the anesthetist, a person, has drugs. Those drugs are called anesthetics. ANESTHICTS. Anesthetics. ANESTHEITCS. Anesthetics. Let me recount. ANESTHEITCS. Anesthetics. So the anesthetist, the person, has some drugs which I will explain called anesthetics. And then they inject or they apply or you inhale those drugs, and you go to a state called anesthesia. Anesthesia. So the anesthetist, that is the personnel who has the drugs called anesthetics. And once they give it to you and you lose your consciousness, whether fully or partially, and in that state whereby you've lost part of your consciousness or fully, you are in a state called anesthesia. So just to give you an idea. So this certified, registered nurse anesthetists, they are not medical doctors who are trained to do this. They are now registered nurses with a master's or doctoral in nursing practice, DNP, who have been trained to administer these drugs called anesthetics. So what do they do? What do these anesthetists do? This CRNAs, this subcategory of our advanced practice registered nurse. Now, for instance, in the hospital where we have surgery, and the place where they do surgery is called a theater. This anesthetist will come to your bedside in the hospital room, and they will talk to you, ask you, are you aware that you're having surgery? Yes. Could you please tell me the kind of surgery that your doctor has said you're going to have? And then the patient may say, well, I swallowed something. It's not in my airway, but I swallowed something, and the doctor has said it is stuck in this gut when you swallow. So it is stuck somewhere, and they need to remove it. Then the anesthetist may say, correct. You're aware. Did he explain about the surgery? Yes, he explained, and I understood. So after that, the anesthetist will say, okay, so while the doctor is going to remove it, I am the one who will be managing your pain level, and I'm also going to give you some drugs called anesthetics. And these anesthetics will put you to sleep, so that when the doctor is removing that object that is stuck, you will not be aware of what is happening, because we don't want you to be moving around. It can cause perforations. It can end up causing more damage when you're moving around. And yet there's a tube going down your throat. So we don't want that. We want you to be still for safety's sake and also for comfort's sake. And then once it is removed, we also give you pain medications before, during, and probably after for your own comfort. That way, when you wake up and you're alert, all you know is that the object has been removed and there's no further damage that has been done. And so that is what the anesthetist may give you as an explanation and ask you if you have any questions. So after that, and you've signed your consent form that you're telling the anesthetist, yes, I've given consent that you can go ahead and do that. Or you can bargain with the anesthetist and say, please, I wouldn't want to be fully asleep. Is it possible for me to be conscious and see what is happening while this is going on? So he may say, because of the kind of procedure we're doing, it is not possible. This is the only option. Or yes, you can choose and we can do that. And so a signature is given, we call it a consent form. And the next time you'll see the anesthetist is when they take you to the theater. And in arrival at the theater, the anesthetist will meet you. You've already met, you've already discussed. So your anxiety level is low because you have an understanding of what may be going on. So here it is the same anesthetist who normally gives pain medication before, during, and after the whatever procedure. I'm saying whatever procedure because there are many procedures that may need you to be sedated, whether partially or fully. So they manage pain medication. And then when they get you in the theater bed, on that theater bed, it is the anesthetist who now will administer these anesthetics. I want to pause a little bit here. The anesthetics come in varied forms. There's an anesthetic that is like an ointment. They simply apply, and in this place, they want it to be numb. So once they apply and it is numb, they are able to probably inject you. So when they're injecting, you don't feel pain because that area has been numbed. Then there are some anesthetics, those drugs, that they can inject on you in your bloodstream. So they find your bloodstream, they inject it. Once it goes through, you end up being in a state of anesthesia. You don't know what is going on. And there's some anesthetics which they put a mask over your nose, and then they tell you to breathe in. The moment you take a deep breath, you end up being in a state of anesthesia. That is how you fall asleep. The surgeon does his procedure, and then they will reverse you back. Now, in surgery, this anesthetist, we're still talking about the certified registered nurse anesthetist. Tongue twisters. This certified registered nurse anesthetist is the one now who will concentrate on giving you your anesthetic drug to put you to sleep fully or partially. They are the ones who will be monitoring the depth of that anesthetics. So they see whether it has gone down, the depth of the anesthesia, or whether it is too high, and they try to balance. And the reason why they are so important is because your surgeon is right there doing the procedure he needs to do. So if you had been seen probably and told there's something stuck in your gut and they need to remove it, the surgeon or the doctor, they're busy removing it because they're sterile, their hands, they cannot touch anything else. These hands are sterile, they've been scrubbed. All they need to do is concentrate on what they're doing. So it is the work of the anesthetist to determine that you're still alive while the surgeon is taking care of you. Not only alive, they are monitoring your vital signs. Remember in our second episode, I had mentioned the vital signs were your blood pressure, your pulse, your respirations, your oxygen level, and even pain level. So they are monitoring that. How high is your blood pressure going? Because sometimes in pain, the blood pressure shoots. Or sometimes in bleeding, the blood pressure drops. So they're monitoring, making sure that the blood pressure is balanced. If it goes too high, they have some medications, which is not particularly an anesthetics. They have some medications they inject to bring the blood pressure to normal or near normal. If the blood pressure drops, whatever case, they have some medications they inject to bring it back again to where it should be. Then they're also monitoring your oxygen. So you've started off with an oxygen. The normal oxygen really ideally should be between 95% and 100%. So when they start seeing this oxygen level is dropping, they know something is not right in your breathing system. So they have a way of maybe adding the oxygen level to bring the oxygen to where it should be. And when they see maybe your breathing is becoming rapid, they also know how to slow it down while the surgeon is doing what they need to do on the same bed, theater bed. Then the same certified registered nurse assistant also monitors your pain level. I've been to theater whereby while the patient is being operated on, they start waking up. There's one who would also scream. And when they're screaming, then everything has to pause because they realize that the pain, even the surgeon stops. The surgeon pauses so that the certified registered nurse anesthetist or the anesthesiologist, they are able to administer the pain medication and maybe increase the anesthesia so that the patient goes back to being sedated or in a state of anesthesia. The pain level is reduced appropriately, then the surgeon can continue doing what they need to do. Because you don't want to be having that surgery when you're awake. It could be something very painful, you can imagine. So they're managing the pain level, also the oxygen level, how fast or slow your heart is beating, and they have all manner of injectables, medications that they can give either to slow down or to increase these parameters. Other than that, they also infuse fluids. The fluids that you see hanging in the hospital, because surgery is going on. And in surgery, sometimes you have blood loss. So they want to be able they have to be sure that dynamic is being balanced. The hemodynamic is in a balanced state. So that they don't have too much blood loss, the fluids can also help together with the medications they're giving to make sure that the blood pressure, the pulse, everything is stable. So they can infuse the fluids, medications put in that fluid. They can give pain medications, other medications. That is what the anesthetists are trained to do. including blood transfusion. So sometimes the doctor has prescribed blood, knowing that this kind of surgery will require blood transfusing into the patient while we are operating. Again, that is just to ensure that the dynamics are in a stable place. Now, having given you an idea, or I've not finished, after the surgery, again, once you're out of the theater, there's still the dynamics of pain level. So while you're still maybe within the theater area, but after the surgery, the anesthetist is still involved in ensuring that the pain medications are given. They can prescribe and say this is what they want. The registered nurse, we are going to come to this kind of registered nurse. They are called theater nurses. They prescribe and say, this patient, I want you to give them this pain medication and give them this and ensure they get this fluid. And now they leave them in the hands of the theater nurse, but still in consultation with this certified registered nurse anesthetist. So you can even see why this CRNA, who is a subcategory of the advanced practice registered nurse. They are like doctors, but really they are registered nurses. You can understand why they will delegate to the theater nurse and tell them, give this patient, I'm prescribing, I have the authority, I've been given the certificate, the license for you to prescribe this medication. So go ahead and give them 1, 2, 3, 4 to manage their pain. And make sure that their oxygen level is at 2 liters every minute. So they're prescribing, although they're registered nurses, but with more authority to do this kind of things. So I've given you a very clear understanding of who these CRNAs are and why they are at a higher hierarchy level than a charge nurse, than a registered nurse, than a licensed practical nurse, or even the certified nurse assistant. That is our second subcategory. Now, other than this, having given you an idea, where do these certified registered nurse anesthetists work? In a hospital setting, in a surgical center. Some nations have surgical centers. These centers are not as big as hospitals, but they are areas whereby nursing is, where surgery is done. So you know that center, if you have anything to do with surgery, that is where you go. So they don't have other medical conditions and illnesses and emergencies. It's basically for surgeries. So you may find them working there. You may find them working in medical offices. So doctors, like I've mentioned, even dental offices, the doctors may prefer to have an anesthetist, a certified registered nurse, anesthetist working with them, so that they just focus on doing the surgery or operation that is required. Fine, on to the third subcategory. The third subcategory of our advanced practice registered nurse are what we call the nurse practitioners. Now, nurse practitioners, it is a very simple understanding. They're as good as doctors, only that they don't do as much as doctors. Remember, our certified nurse midwife, the first subcategory, they were really focusing on the reproductive health and the women, the female gender, and the pregnant women. In a way, they've specialized in a line of women. And then the anesthetists, I've described to you what they do, so you can see it is somehow limited into administering anesthetics to put the patients in a state of anesthesia. Now, these nurse practitioners are what a doctor would be like, only that they are registered nurses with more training, but they don't do everything a doctor does. But these nurse practitioners may decide, I'd like to work with the elderly. So when they're doing their training to get their nurse practitioner certificate, they know that they're training as geriatrics. The geriatrics are the elderly. So we call them geriatric, and sometimes they interchange the words, and they're called gerontology. So it's either geriatric or gerontology, nurse practitioner. So the geriatric nurse practitioner has decided, I'm going to be the doctor, but a doctor that serves the elderly. And another nurse practitioner may say, I'm going to be a doctor, but I'm going to be a doctor that works with the children from birth until 18 years. And so they're called pediatrics. So we have pediatric nurse practitioner who has decided to work with the age bracket from birth to 18 years. So we call them pediatric nurse practitioner. So they are the doctor. Anything illness, anything injury, anything a doctor really would do, the assessment. Remember, they are advanced practice registered nurses. This is just a subcategory. So the description I've given you of what a normal doctor would do: assessing, diagnosing, interpreting the diagnosis, and then prescribing treatment. Only that they're focusing on the pediatrics, the children, or they're focusing on the elderly, geriatrics, or they're focusing on the entire family. So by this, it doesn't matter whether it's pediatrics, it doesn't matter whether it is adults, it doesn't matter whether it is your grandparent, your grandfather or mother, they will take care of them because they are a family nurse practitioner. Simple as that. That is what nurse practitioners do. Or they may decide that, yes, they want to be nurse practitioner, but they're not looking at the patient population. They are, if anything, focusing on the type of care. So they may decide, I will care for the patients who have cancers. Only that I'll act as a doctor for patients who have cancer. And this line is called oncology. So they are oncology nurse practitioners, because they care for cancer patients. So anything a doctor will do, only with limitations, which they have now been trained, this is all you can do because you're a registered nurse, only that you are doing an advanced practice. You've gone beyond a basic total nurse. You have had some years of experience. You have had training. Now you'll be a nurse practitioner. You'll act as a doctor to this line you have chosen, whether cancer patients, or they've chosen critical care, or they've chosen emergency care, depending on the line they've chosen. Or you've decided pediatrics or geriatrics or the whole family. So you're a nurse practitioner, you're acting as a doctor, but with limitations to the line that you have chosen. Simple. Nurse practitioner. That is what they do. So we've done 3 subcategories of the advanced practice registered nurses who are above the charge nurse that we discussed last week. Certified nurse midwife, CNM. We've done certified registered nurse anesthetist, CRNA, and I've just explained a nurse practitioner. And our final subcategory, they are called clinical nurse specialists. Clinical nurse specialists, CNS. Now, the CNS, they don't do direct care to the patient. They are registered nurses. They must have masters or a doctoral nursing practice, DNP. So they either have PhD in nursing or masters in nursing. Of course, they've had years of experience as registered nurses because they are advanced practice registered nurse. Remember, they're a subcategory. So they've had this, but for them, they've decided they're going to do research on a certain area. Either research on a patient population, the pediatrics, or the adults, or the geriatrics. They've done research in these areas, or they've done research in oncology, cancer, in gastroenterology, the stomach and the intestines and all that, or they've decided to focus on the critical care. That is why they are called clinical nurse specialists. Mark the word specialist, bold, italicized, underlined, specialists. Now they've decided to do research, go deeper, find out more about that line they have chosen. And then they use that expertise to advise, to recommend, to share the knowledge. So you can see they're really not like nurse practitioners or the certified nurse midwives or the CRNA, whereby they do the hands-on, whether giving anesthesia for the CRNA, or they're taking care of the pregnant woman for the CNMs, or taking care of the family, doing the assessment, diagnosis, what have you, for the nurse practitioner. For them, they gain the knowledge, do in-depth study, and then share the information they have gathered. So they advise, they recommend. These are the kind of a group of people or the cadre that would advise. Probably they'd see a shortcoming. They end up seeing a shortcoming, let's say in a hospital setting or a healthcare setting. And that shortcoming could be something like the hospital is going at a loss. At a loss, they're not meeting their goal because financially things are not looking good. The certified nurse, clinical nurse specialists come in with their expertise. They're able to tell maybe it is poor usage of the supplies available, long hospital stay by the patients. They're able to look at those loopholes, those gaps, because they've been trained. They've been trained in a certain line. They're able to pick those shortcomings and then advise or recommend or give the expert advice to the healthcare setting. Once implemented, then the problem is sorted. Another thing that they are able to do, for instance, if there's they want to cut down on the hospital stay, maybe patients are staying too long before they get well, they're able to see that loophole, then come up with a suggestion of what can be done for patients to have a shorter stay. For instance, the pregnant women that have cesarean section. In times past, pregnant women would even be in hospital for 2 weeks, 1 week, post-surgery. So to avoid this long hospital stay, they may come up with their own expert advice that would ensure after cesarean section, which we call C-section, they only stay for 3 days and they're discharged. Those for normal births, they stay for a day or two, then they're discharged. So they can come up with such advices, giving their reasons, what they have found out, what their research says, I could go further. There are many examples where their information is really valuable. So they're like doctors because they have studied further in depth in this line. And when they advise and implemented, then a change is seen in the healthcare facility. Fine. Our clinical nurse specialists, that is it. I have given you a rough idea of what they do. Now, where they may work with insurance companies. You can imagine why. They have done research, so it is very easy to advise the insurance company on various issues when the claims are made in the healthcare facilities. They come in, and then even the legal practitioners, they advise them, they give the expert advices, recommendations, and what have you, for them to carry out their legal practice. They're seen in hospitals, like I've mentioned, outpatient clinics, they're there. Long-term cares, they may be found there too, because they really save the healthcare facility. They save them financially in terms of patient quality care, because once they give the advice and it is implemented, you can imagine whatever was going wrong, once it is changed, then the patient satisfaction increases. The care of the quality increases and the satisfaction of the patient increases. And by that, even the hospital standard is raised. That is our clinical nurse specialists, CNAs. So in general, I've talked about these 4 categories, subcategories of the advanced practice registered nurses who are above the charge nurses. Now, a disclaimer. In some health facilities you're going to hear of the nurse managers. They fall somewhere in this line. Somewhere in this line, meaning they're above the charge nurses. So the nurse manager will end up being in charge of the charge nurse, the RNs, the LPNs, and the CNAs. But for the sake of these major cadres, I am moving on from the APRNs. Now we're moving on to the Director of Nursing. If you were in a class, I'd say any question at this point. But because for purposes of discussing, if you have any question or any comment, throw it in and we can all discuss together. Where there's a loophole, we can see how to fill it up. Now, our next category, the Directors of Nursing. There is not so much I can say about this category, other than they really are about leadership. Leadership and collaboration of their nurses. Now remember, we are having CNAs, LPNs, RNs, we are having CRNA. Like I mentioned in our last episode, you don't want anyone to say, I know my role, I'm simply going to go in and do my part and leave. There has to be some form of coordination, teamwork. For the safety of the patient, kindly remember safety. The patients are the reasons we are all there. They are the reasons that healthcare facility has been set up. So for the safety of the patient, there has to be some form of order. Our God is a God of order. Nursing is a ministry. It is a ministry, it is a profession, but it also has order. So, the director of nursing, remember what I explained about the charge nurse taking care of an entire unit or being in charge of the entire shift. Now you can imagine you have a charge nurse with her team in Ward A, another charge nurse in Ward B, another charge nurse in Ward C. Then that is just the medical surgical unit. We have probably the endoscopy unit where they go in to check inside the tract, from your mouth to your behind. If you have that unit, you have a charge nurse there with her registered nurses and licensed practical nurses, maybe even her certified nurse assistant. So there are very many wards probably, not just these 3 wards. There's another section of the hospital, maybe the orthopedic area, where they're dealing with patients with bone diseases and fractures, and they've gone through surgery. That is again another unit with their own charge nurses and registered nurses. So the setting may be big, whether it is an outpatient setting or a hospital or long-term care. So in order to coordinate all these charge nurses and her teams, we have what we call the Director of Nursing, the DON. They may go by any other names, but the Director of Nursing is now overlooking the charge nurses together with her team of nurses. And not just the charge nurses. The Director of Nursing is, let me say, her main role is to, how do I put it? Her main role is to overlook and to care for her nurses. She advocates, that's the word. She advocates for her nursing team. Nursing team, it involves our CNAs, it involves our LPNs, it involves our RNs, it involves our charge nurses, it involves our APRNs, advanced practice registered nurses, of which I've discussed the 4 categories. So the Director of Nursing advocates for this team, the nursing team. Nursing team. By this, I don't mean that she advocates for the dietary team. The dietary team have their own head, maybe the head chef. The dietary team have their head chef who will advocate for them, or the head nutrition, dietitian, whatever title they may go with. Now, the Director of Nursing is concerned about any of her nursing team members. And whom is she advocating to? The one above her, of which you're coming next to discuss. And that is the CNO. So she's in between. By this, there are concerns that the nursing team may have. Concerns about maybe the nurse-to-patient ratio is quite high or quite low. Meaning the nurse may say, we are only 3 registered nurses, but in the unit we have 30 patients. So 30 patients with 3 registered nurses, meaning the nurse-to-patient ratio is 1 to 10. 1 nurse for 10 patients. Another 1 nurse because there are 3 registered nurses. The patients are 30. Now, if we have 1 nurse to 10 patients each, a nurse-patient ratio of 1 to 10, it is too tasking. And they'd like the nurse-patient ratio to be increased, so that they have probably 5 nurses to the 30 patients. Now, this is something that the Director of Nursing will take up and escalate it to the the certified, the chief nursing officer, because there's a problem. The patients are more than the nurses can handle, and that is tasking, and also it breaches safety matters, because this hierarchy is supposed to look at the safety of the patient. If you have too many patients with few nurses, there's a high chance things won't go well in the unit with the patients, and that is not supposed to be. The reason patients come to the healthcare facility is so that they can get better and return back home and not die in the facility. So that is one of the things that the director of nursing can advocate for her nursing team up to the chief nursing officer, so that they can see whether this can be remedied. And then another thing, something as simple as nursing uniform. So probably the facility has been having the uniforms whereby they wear tops and skirts. And for the nurses, they may say it is not comfortable for us because we have to bend, we have to pull things, we have to lift patients. Sometimes it gets hot. You can imagine you're having the uniform, you're in a bathroom showering a patient, the door is closed for privacy, the patient is bathing hot water. Now all that steam inside that room, maybe it's an ensuite room, there's no window, the uniform becomes uncomfortable. So they can escalate something like that to the director of nursing, and the director of nursing takes it up with the chief nursing officer to say the nurses are requesting if the uniform can be changed to a scrubs uniform. Scrubs is the light top and bottom like trouser kind of uniform. It makes it easy because it's loose, and so air can flow in. The sweating is not so much. It is also lightweight. Should it get wet, it's easier to dry. So they can look at the material of the uniform and say the skirt and the blouse, or the top and the trousers we've been wearing, the material is heavy. When it gets wet, it takes long to dry, making it uncomfortable to go through the shift. Kindly change it to scrubs uniform, so that if it needs to be changed, it can be changed quickly, or drying may become easier, or it's comfortable. Or the uniform makes you so hot, so cold, it could be that they're wearing scrubs, the lightweight, and yet during night shift, it becomes uncomfortable because it is cold, it is chilly. Could you please add in the uniform so that we have fleeces? There are some form of sweaters. In that way, you won't see one nurse wearing one label of some hood, another one is wearing the home sweater. So that kind of uniform, it's not fitting in a professional manner. So these kind of things matters uniform, matters nurse-patient ratio, matters even policies. Maybe there's a policy that the nurses feel is not sitting comfortably with them. Procedures that they follow, that they feel there could be a better way, and they'd require changes. These are the kind of things that the nurses communicate to the director of nursing, or the director of nursing observes, discusses with the nursing team, and then escalates it to the chief nursing officer for some changes to be carried out. And by that is when you now see there is the performance level increases, the hospital goals are met because there's compliance between the administrator or administration and the nursing. And this, ladies and gentlemen, could be one of the major reasons why you'd hear of a nursing strike. The nurses would go on strike. Why? Maybe because they've brought up an issue that is really making their work almost impossible. And they cannot take it anymore, and they've decided to say, because this is not being handled, we cannot go on. Until it is dealt with, that is when now we can go on. And most of the time, by the time they do that, probably they've escalated the matter time and time again, and nothing is being done. So it is always important for it to be looked into, and then an agreement is settled, because it involves the budget. Almost always it involves the budget. For the nursing uniform to be adjusted, it costs the facility money. So the financial implication may make the administrators maybe not deal with it, but that is something we're going to discuss in our future episodes. I'll bring it up in one of the episodes, and we're going to look further into these matters. For right now, I just wanted you to understand the importance of the DON being between the nursing team and the administrators or the chief nursing officer. Now, why I have said administrators or the chief nursing officer is because in some facilities, the director of nursing is the highest level in this hierarchy. Like a long-term healthcare facility, she may be the final authority in nursing in that facility because it's not a very big facility, so they don't have too many units. So some facilities like long-term care facilities, which we'll discuss later what kind of facilities these are, the director of nursing is the highest authority, while in others now they escalate to the chief nursing officer. That is our DNO. Now, our final and highest point in this hierarchy level is a chief nursing officer. The chief nursing officer is the overall authority of all the nursing teams in that facility. That's why I said in some facilities it is the director of nursing, but in others, most especially hospitals, you will find a chief nursing officer. Now, this is an executive level of nursing, an executive level office, whereby it is the chief nursing officer that is answerable to the CEO, the board of that hospital. Rarely will you see the director of nursing sitting in the board. It will be the chief nursing officer sitting in the board and giving information on her nursing team. Remember, chief nursing officer, nursing. So her main line of interest in that board office are the nursing team from the CNA all the way to where she is, the DNO beneath her. So the chief nursing officer is the one that gets information about what the national regulations are. So wherever the country or the nation, the facility is, they do have regulations of what they require of the facility that they have to follow. So these regulations are discussed in the board. This chief nursing officer has to be aware of whether there are 50 regulations that the nation, their own country, requires every health facility should adhere to. They know those regulations and they share it with their directors of nursing, who shares it with her team of nurses from the charge nurse down to the CNA. So the chief nursing officer sits in the board meetings of the health facility. She is answerable to this CEO. She's the one, the picture of the entire facility. For instance, during COVID times, you will see the chief nursing officer. She's the one who will come out and discuss matters, her facility, matters, the hospital, how many COVID patients the hospital received, because she has all that information. Time and again, you'd see the CEO, Chief Executive Officer, but it is the Chief Nursing Officer now who comes to give that information about the situation on ground pertaining matters nursing. Okay, another thing is about policies and procedures. The CNO, again, is aware of the policies and procedures, communicates it to the director of nursing, who shares it with the nursing team. I will backtrack a little bit. A very important matter concerning these policies and procedures. The director of nursing is the one that implements these policies and procedures on ground. She shares the policies and procedures because she has received that information from the chief nursing officer. So she'll go ahead and share these policies and procedures with her nursing team. So you may hear of meetings. We had so many of those meetings. Sometimes when the nurses show up for duty, they would have probably 1 hour meeting before they start the shift. So the shift that was there previously will have to hold on for an extra 1 hour because the oncoming shift are in a meeting. And in that meeting is being communicated matters, policies, and procedures. whether new policy and procedure that has been introduced, or there's an adjustment of a nursing policy or procedure based on maybe the politics of the country, whatever. So they're being shared this information. That way, when they're going ahead into back to work, they now know things have changed. This is now what you're doing versus what we did yesterday. And the outgoing shift may end up, after shift, they may also end up having a meeting. So after shift, they go for a meeting again to be updated, or when they'll be coming back tomorrow for a shift, they may enter, spend an hour or two in the meeting before now getting into work. That is nursing for us. We do have such meetings whereby policies and procedures are being communicated, whether there's an update, whether there is a new policy procedure, it is being communicated by the director of nursing. Like I've said, I've just backtracked. Pardon me, please. Again, the director of nursing, another important part that I've left out, this team of nursing in this hierarchy, they also conduct what we call continuous education program. This is whereby, when you may, a facility or nurses, you may end up doing something over and over again, and yet there has been progress of how to do it better and even in a more safer manner. So this director of nurses set up time, the schedule of when something can be, a certain procedure can be discussed in depth so that the nurses are aware that things have changed and they learn something new. And even if there isn't something new, to refresh the memory. Because some nurses, they've been there for 5 years since they left college, 10 years, some 30 years. So instead of doing something over and over again, and there's a new practice that ensures patient safety or a shorter hospital stay, or it cut costs, those kind of things. So when the director of nursing, they set up these programs so that the nurses are aware of the new practices, and it is an ongoing teaching. It also keeps the old practices fresh in mind, and even the new nurses get to learn as they practice their nursing. So they get to refresh their memory, even things that they don't come across time and time again. Some procedures you may end up doing maybe once in 3 months because you've not had a patient who requires it. For instance, getting a bone marrow sample. There's a certain procedure to it. So it's not every day that you have a patient who has been prescribed to have a bone marrow sample taken for diagnostic testing. And so you can imagine when you have a continuous education program that the director of nursing has scheduled on Thursday at 3 p.m., and the nurse attends this program, they're able to refresh their memory. And good luck if the following day a patient comes and the physician or the doctor has prescribed that they should have a bone marrow sample taken. That is what the DONs do. They set up these programs, set up the schedules, and prepare even the timetable of what is being discussed in the programs. I could go on and on about our directors of nursing, but I hope with the coming episodes, whatever it is I've left out in these cadres, I'll be able to bring it out, and then you'll remember who CNAs are, what they do, and add on to whatever it is that I will be adding on to you. So back again to our Chief Nursing Officer. She's there, liaising between the administration, sitting in the executive level. She's in the board meetings. She's receiving the new and updated policies and procedures, communicating it to the director of nursing. But also, remember, she's representing her nurses. She's a Chief Nursing Officer. So in that board meeting, she's there for her nursing team. So she also has to present all the information, all the complaints, everything that the nurses require to perform to optimum level, and share it with the administrators, because it is not the DON, unless she's the highest level of authority, sitting in that boardroom to say what the nurses are saying concerning their uniforms, concerning their maybe shift hours. They'd like it reduced from 12 hours to 8-hour shifts, or even they want it extended from 8-hour shifts to 12-hour shifts, only that the days they're working in a week, they don't want to be working 5 days in a week. Instead, they want to be doing 3 or 4 days in a week. So it is the CNO in the board office who will say the nurses are requesting, the nursing team is requesting for the shifts to be changed from 8-hour shifts 5 times a week or 5 days a week to 12-hour shifts 3 or 4 days a week. And then the administration will listen, deliberate, and sign up a new policy and say, okay, from today onwards, the shifts have changed from 8-hour shifts to 12-hour shifts. Then the CNO will communicate it to the director of nursing, or the entire team will get the information that the shifts have changed. Ladies and gentlemen, I think you have a better understanding of who a CNO is, where she's sitting and whom she's representing, and the kind of advocacy she carries on for her nursing team. I'm going to stop there in matters hierarchy. We have started off from the certified nurse assistant. We have moved on to the licensed practical nurse. We have moved on to the registered nurse. We have moved on to our charge nurse. We have moved on to our advanced practice registered nurses, APRNs, who have 4 subcategories: the certified nurse midwife, the certified registered nurse anesthetist, the clinical nurse specialist, and the nurse practitioners. All in this level, they are advanced practice registered nurse. Then the one above them is the director of nursing. And then finally, I have taken you up to the chief nursing officer. That is the hierarchy in nursing. Not so complicated, but it helps us. It helps us to work as a team. It helps us to be coordinated. It helps us to at least ensure there's quality care. It helps us to ensure patient safety, and more that I'm going to discuss, and you'll see the importance of having these cadres. And now I hope that when I'll be mentioning them, you'll be able to understand who is who and what their practice level is. Now, all this, I cannot speak it without including our Bible and why this is a nursing ministry channel. It is a nursing ministry channel because, go with me to Matthew chapter 25. There, in Matthew chapter 25, verse 36 thereabout, it speaks of Jesus saying or giving a parable, it was a parable, because or a statement, and he mentioned, I was naked and you clothed me. I was sick and you cared for me. I was in prison and you visited me. This is Jesus speaking. Then the person asked, Lord, when were you naked and we clothed you? When were you sick and we cared for you? When were you in prison and we visited you? And Jesus answered, when you did that to the least of these, your brothers, you are doing it unto me. In other words, when we do these things to others, whether our family members or the community, really, we are giving it to the Lord, and it is He that will repay us. So the person that we are caring for may not repay us, but our reward comes from the Lord. Why am I saying this? I promise that I'm going to discuss how we can apply this hierarchy in the family or in the community. Now, we have nuclear families, we have extended families, some are called blended families, all types of families. Even orphanages really are families. An institution whereby people are knit together as some sort of a family. Now, in other words, when I say family, I mean people around you that you are knit together for a common goal. If it is in the house, you'll have the father, the mother, the brothers, the sisters, the house manager, house help, whichever term you may use. And then one person falls sick in the family. When this person is sick, you have to bring out the CNA in you, bring out the LPN in you, the RN in you. All these cadres are in you. Now, I've already described what CNAs do, LPNs, RNs, and registered nurses, and all these levels to the CNO. So I'm just going to bring it out and then relate it to the cadres I've described. When somebody is sick in our midst, for instance, in the family, the younger ones can do chores like cleaning the environment where that person is sick before going to school or before going out to play. They won't be denied their play. They won't be denied going to school, but there is somebody sick in the house. So instead of abandoning this person and saying, we have hired a nurse, we have hired a CNA taking care of them, everyone wakes up, get ready, take their breakfast, say goodbye, and they go on to their duty. In the evening, they come back, those going to the TV, those changing from their uniform, going out to play, yet there's a sick person in the house. I just thought it is best to educate and let everyone know there is a nurse in each and every one of us. And that nursing skill should, and really it must be applied to take care of that sick person in the house. So the little ones can do chores in the house. They can wash the dishes and then verbalize. Let that sick person hear, Mom, Dad, I have washed the plate and the cups and spoon that so and so, who is a sick person, used. When the sick person hears that, it is therapeutic. It is therapeutic because they know their little brother has taken the plate they used, the cup and the spoon, and they have washed it. Then another sibling or a brother or sister may go ahead and mop the environment where that sick person is. Just being in that sick bed and seeing your sister move things around, cleaning the windowsill, wiping your window, mopping the floor, it is therapeutic. Remember, nursing is not just about physical or it is not just physical, giving you medications and bathing you. You as a person has a physical side of you. You have a mental side of you. You have a physical, mental, emotional side of you. You have the spiritual part of you. So each of these areas have to come to balance for you to be whole again. So no matter how many medications you're taking, if mentally or emotionally it is being affected, it may delay, it may prolong your healing. But when you see that brother or sister cleaning around you, someone is on the window cleaning, the curtains are being brought down and changed to cleaner curtains, you've been sat, the older ones, if it is safe, they can help you sit on the seat next, change your beddings for you. That bedding may be soiled with urine. That bedding may be soiled with stool. That bedding may be soiled with blood. That bedding may be soiled with sweat. Sick people, when they have fever, they sweat a lot, which makes me shed my sweat. But they do sweat a lot. So the beddings may have to be changed every hour. Patients with TB, you may end up changing the beddings even 3 times in 24 hours. Because there's this heavy sweating, profuse sweating. So even if there is a nursing personnel that has been hired, each and every member of the family, when they bring out the CNA in them and they do this work, even though the health personnel is there, before they go out to school or before they go out to work, it promotes the healing of that person that is sick. They will know Mom has gone to the business area, Dad has gone to work. Yes, my elder sister is in college. My younger brothers and sisters are in school. I'm left with the nurse and the house help. But guess what? They were in the room before they left. They took care of me. Dad did this, Mom did that. My brothers did this, my sister did that, and they left. So you leave them with a mental state of, my family cares. My family loves me. My family wants me to get well. And such patients are likely to cooperate with their treatment. By the time the certified nurse assistant attends to them, or the licensed practical nurse gives them their medication, for instance, they will take it because they want to get better and, make it easier for the family, and not that they are bothered about them doing it, but they want to be restored back to the family and back to normalcy. It's very possible that they'll cooperate. When you return, I've only mentioned what the brothers, the sisters are doing. Not just cleaning. What about the licensed practical nurse in you? Sometimes it may not be possible to hire this healthcare personnel. So you are the licensed practical nurse. The doctor has prescribed the medication. You have gone home. So because now it has been written, this medication, you're going to take it 3 times a day, 20 milligram 3 times a day. So it means you will have to know what kind of medication that is, what is it for, that how many milligrams the doctor wants to take, and by milligrams, how many tablets is in that milligram. Okay, and then should you take it before they eat, during their meals, or after their meals, 30 minutes before or after? This information we gather from the doctor when he has prescribed. And sometimes the doctor may not give the full information. Please, today we have the internet. The Google is there. Healthcare personnel are there that we can approach and ask them, could you please explain this better? You can go back to the doctor. Feel free. We're going to discuss matters communication in one of our episodes. Ask the doctor, should you not get the satisfactory information that he's giving? Ask another one. Ask a nurse in the healthcare facility. Explain better. Don't be afraid to say, how do I take it? Should I wait 30 minutes, an hour, or does it not matter? Before meals or after? Then apply that in being the LPN to your loved one in the family. The registered nurse, of course, you'll be doing more. The doctor may say they want a stool for test. I want you to come back next week on Monday. Come back with your stool for that day so that we can have a test done on that stool. You as a family member, please, if it's a sister to sister, brother to brother, child to their parents or grandparents, it doesn't matter. If you have the heart to do it, we have male nurses, we have female nurses. Go ahead and help them take that stool. Sometimes they could be weak. Go ahead and take them to the restroom. Help them to get that stool sample, cover the tin, put it in your biohazard bag. Once they're ready and you're going to hospital, present that specimen. I can guarantee you that act that you have performed for your loved one will feed into their mental and emotional state and even help them to heal faster because they will feel loved, they will feel cared for, they will be determined also to be well. And there's nothing as good as seeing a patient participating in their own well-being. Because the spirit also is involved in you getting back to be strong. You are determined, you are fighting it off mentally, emotionally, and saying, I must get better. And it cooperates with the medication for you to be well. So that is the LPN in you, gathering the necessary information and helping this sick person so that it is not all about getting the medication from the doctor, no questions asked, no information gathered about whatever medications you're going home with, whatever the patient should be done for while they're at home. The doctor has told you, you need to turn them time and again. Don't just accept turn them time and again. Ask them, doctor, does it mean every 2 hours I should make sure they are lying on one side, or is it just random, or because some it may be every 30 minutes, 2 hours may be too long, and by the time that person you go and turn the patient, they have a sore at stage 1. Remember I mentioned the reddened area? Because you did not gather more information, turn, but how often in bed or in a sitting position? So please, let's be registered nurses. Let's be licensed practical nurses. Gather more information and be the ones applying it at home. Then let there be a division of labor. While the little ones are cleaning the house, another one is doing the plates and the dishes and making sure that the patient has had that you have cleaned the room, you have washed the plates, you have washed the clothes. Maybe they soiled, they passed urine on their own clothes. Let there be somebody in the family saying, I have washed. Much as there may be a house help who can do that laundry. But it would be much better if a family member does it and you ensure the patient has had you communicating, I'm going to wash so-and-so's clothes, they are soiled. When they apologize, please Tell them don't apologize. It is okay. It's the state you're in. You'll get better. You'll be okay. Don't worry about it. There is something it does to the psychology of your family member who is sick. When there's an appointment to the hospital, if it is a Saturday, if you're not in school, they're not in college, you're not in business, you've not gone to work, the whole family can accompany this sick person to hospital. Instead of sitting watching television, instead of going out to the mall, instead of going out to a party, those things can be suspended. If this sick person sees the whole car is full, taking them to the hospital to hear what the doctor says about their condition, how they're doing well, this sick person will get better much faster. They will get well fast. And peradventure, death is a part of living. Peradventure, this person dies. How many times have we seen parents blessing their children at the deathbed? At the deathbed. I'd like to bring in a Bible story of Esau and Isaac. Esau and Jacob. Jacob was near his father. What if the father took that meal and then blessed him and he died? Esau, who was out trying to get the meat for the father, having returned, what if he found the father dead? There is something the father spoke to Esau. He told him, if you get restless, you'll break the yoke off your neck. Had he not had that blessing, Esau would have remained in bondage all through. And he would have missed the slightest of blessing that helped him get out of his situation. Because by the time Jacob met him, he had so much that he didn't even need what his brother Jacob was offering. There is something about, should they not get well, but the blessing of just telling you thank you. The blessing of just telling you God bless you. Telling you I love you, I appreciate. Oh, God bless. You will hear it so much. Things line up in life. Things line up. That is why I say it's important for families to be involved. Be involved in the sick loved one. Be it doctor's appointment. Be it in administering what the doctor has prescribed. Be it in taking care of them. Even though you may have your bed in your bedroom, you can bring a mattress and sleep on the floor inside the bedroom where the sick person is, if their health allows, because sometimes it may be something communicable, maybe it is not quite healthy for you to be around, not so critical for them to be in hospital, but so that it is not past, they're not fully well, it may not allow, but you can still wake up. Every hour, every 2 hours, go in shift. Let somebody enter, spend the night. The next night, let somebody else spend the night in the bedroom. The following night, and on and on and on until they recover. Take them to the toilet. Yes, there is a certified nurse assistant. Yes, there's maybe you've managed to hire the LPN or you've hired the registered nurse. Let them do those critical things. But sometimes if they are doing something and you feel this is something I can do, we do allow the family members to participate. So if you may see, it is about crushing this meds, let the registered nurse give you the medication, and while they're watching you, the sick person is watching you crush that medication. You are not the one who dispensed the medication. It is this registered nurse. It is this licensed practical nurse. All you're doing is doing the crushing. You ask the registered nurse, is it okay? You're working with them. Why? Because this medication, we want to give it to my brother. We want to give it to my sister. We want to give it. There's no harm in that. But doing that, you are really communicating love and you're promoting faster healing. Now, you may say, so where is the CNO in all this? The CNO is not doing the cleaning and the bathing and the changing of linen and the crushing of medication. Now, the CNO can be the one coordinating all this. Because I've noticed in some families, there are people with a soft heart. They have a light heart. It touches them so much, being around their sick loved one. It can even break themselves mentally. So we have to give room. Let people do what they can do. That's why some CNAs remain CNAs forever. They don't advance to become LPNs or RNs because it's their calling. It's something they enjoy. They're okay doing what they're doing. So if you have a family member who feels comfortable doing the bathing one. Don't say you're old enough. Leave the bathing and the washing of clothes to so and so. Go ahead and do. No. Let everyone find their space, but ensure that everyone finds a space. Everyone should find a space, but the one that they are comfortable in. Everyone should find a space, but it should be their space. So that if the little one, you feel that they're not comfortable with doing what they're doing because maybe emotionally it's doing something to their emotion, but they can do something else. Maybe there's some solutions that can be mixed. They can fetch water and then pour it in a bucket. This bucket requires 20 milliliters. This one requires, 20 liters. This one requires 5 liters for the soaking of the beddings or what have you. If they're old enough and the nurse can demonstrate it to the family members and them, the one who is the CNO can ensure that the little one has done, they have fetched the water in the buckets before dressing up and going to school. That is their space, but they have picked a space. And the patient knows that brother so-and-so has fixed it up, as put in the water in the buckets before going to school. There is love that has been communicated there. Now the chief nursing officer is coordinating, ensuring the water in the buckets are in place. It's not that water that was used yesterday. And if it wasn't done, they call upon whoever is responsible and tells them to do it. If there is any kind of, not animosity. If there comes any kind of clashing or a misunderstanding amongst themselves, it's very important for the patient not to be near that vicinity. So don't quarrel, don't argue, don't come into disagreements or misunderstandings. Oh, it is me who did it yesterday. Let so and so do it today. Oh, how long are we going to do this? I'm tired of, please. For the sake of your family member, for the sake of the sick person, take your complaints further away. Take your weeping further away. We all have tears. Weep further away. Go and release it. Go and share it with the family members outside. Because the moment this sick person gets to hear about how it is draining you psychologically, mentally, those are the times you start hearing comments like, I'd rather die and not be a burden to anyone. I don't want to be alive. You know, why should I be here and make you people not go ahead for your parties and your... So any kind of a state whereby you're not comfortable, it is important to take it away from the sick person for the health of this person and for the faster healing of the patient. So we have our DONs and our CNOs in the family coordinating all that is happening, and also they can be the in-between and advocate for the patient to the doctor. So when we go for the doctor's visit, they can be the spokesperson, tell the doctor, yes, we've been doing this and that and the other, and what have you, so what else do we need to do? Once communicated, they can come and tell that little brother, now you're going to be washing, but before you wash, Sister so-and-so is going to be giving you a special bucket of water. So don't be washing with the tap water. The doctor said you're going to be using a special kind of water. Be asking Sister so-and-so to be giving it to you, and that is what you'll be using to clean, because that is now the new rule that the doctor has given. Then go to the kitchen and tell the house help. Now the doctor has said, please, you're going to reduce the salt. Don't be putting the salt in the plate, please, when you're serving, when we're preparing our patients or our sick sisters' food. Be cooking, and the doctor said we can be using maybe a quarter of a teaspoon in the food when we are cooking, and then we serve. So please, when you're preparing the tray, don't put the salt shaker on the tray. I'll come for the tray and serve our sick sister myself. You see? So our DON in the family knows everything the doctor has said. They've come and communicated it in a language that our CNA in the family, our little boy, understands. They've told They've told our house help in the kitchen, our dietitian what to do, even though they're responsible for the nurses. They've communicated. So now the patient is getting what has been prescribed. The healing happens faster. Then you may say, what about the community? Oh, time does not allow me, but I'll take 2 minutes. For the community, if you hear there's a sick person in your neighborhood, in the community, how many times have we seen sick people in hospital, but they don't have a family member around? Especially, well, let me not mention, okay, especially the general hospitals. Because maybe they may be strained in terms of personnel and all that. So maybe they've been referred from a different county, an outside county, or a different state, or even a different country. So by the time they come, their family is not anywhere near, but they're in hospital. So while the other patients are being visited, the other patients have their loved ones by the bedside, helping them go to the toilet, taking them to the bathroom, bathing them in bed, mashing their food for them and feeding them, buying them milk because maybe the hospital hasn't provided milk for the lower level hospitals. The budget may not allow, or they have everything there, but there's no one really to feed them because their personnel, the nursing nurse-patient ratio is strained. So really, by the time they're eating, maybe the food is cold, or they're not eating because they don't like cold food. That is where you come in for the community. I don't know about the recent now, but there is an opportunity to go to these facilities, talk to the doctors and the nurses, and tell them you'd like to be able to be of assistance to the patients. What is it that you can do safely? Please mark the word safely. I talk about safety because there are cases whereby the patient hasn't eaten for a long time. The patient doesn't have family around them like I have described. The dietitian has served food and left it at the bedside, no one to feed the patient. But because you have a good heart, you go to feed the patient. Suddenly the patient feels they're hungry. You feed them rice and beans. They haven't eaten for 6-7 days. You feed them the rice and beans. You're happy, you have health. Surely your reward is in heaven. Because as Jesus has said, when I was sick, you cared for me. Definitely there's a reward. But guess what? That patient can die. Because they have not eaten for a long time, you've given them solid food. Instead of escalating from maybe juice, milk, fluids, water, soup, and then the following day they move to something pureed, and then the next day they move to a semi-solid food before they can eat that rice and beans. So sadly, the patient dies. Those cases are there. Such cases have happened. Yet they happen from somebody whose heart was truly pure. They went to serve. They saw patient wants to eat. The patient was happy. They found somebody who can feed them because most of the time maybe the food is cold, or by the time they're collecting the trays, they assume this patient doesn't want this food. And because they don't want the food staying there, it will rot. They keep changing trays of food at the bedside. So please, always in serving the community, consult with the healthcare personnel around, if any. If there's a nurse, ask them, what is it that you are doing that I can do? The word is safely. If they say yes, you can help. If it is bathing, you can bathe them. If it is feeding, you can feed, but you can help me mash the food, but I will feed them. The CNA may say, please mash the food for me, but I will do the feeding, because they end up aspirating. They cough frequently when they are eating. So I have to do it in a safe manner, or there's something that they have to be given in between their meals. So let me do the giving them the food, but you can do A, B, C, D. That is safe. Your reward remains where? From the Lord. So that is how you can serve the community in these healthcare facilities. Always approach the nursing station. Ask what you can do safely. If given the permission, go ahead and do it. And please work together with the healthcare team available. Should you be taking care of them and something happens, rush for help. Don't panic, don't disappear, don't see somebody, their breathing changes starts when maybe you are changing their bed linen, and then you panic and you leave them thinking you'll be blamed. No, you asked for permission. You are given permission. In fact, that is the best time to immediately rush back to the nursing station and say, the patient that I'm taking care of in room number 4, Mr. So-and-so, is breathing funny. Please come and check on them. You have done far and beyond. You've done a very noble thing. That is how you can serve the patient in the facilities. If at home they're not in the facility, please do what you can. Financially, you may be in the city and the sick person is in the village. Don't say, well, I have to go to work. They'll understand. I'm not able to get leave. Send your money. Send your money and instruct and say, please buy these fruits. Or if they can't eat fruits, please, I have sent this juice coming. Let them drink the juice. Let them drink the milk. I've bought it for them, And then let the sick person, if possible, let them hear, Uncle so-and-so has sent money. We have bought juice. Here is the juice from Uncle so-and-so. What does that do to them psychologically, mentally, and emotionally? It tells them people are in the city, but they've not forgotten me. They love me so much. They care about me. They've even sent money for milk to be bought. I could not eat. My family probably was strained financially, but I can drink milk and I am healing faster. That is how we are serving. Cases whereby grandma is sick. She's in the village. Yes, she has auntie taking care of her. But around grandma, the grass lawn has grown so tall. It looks like a bush. Yes, you may not be the CNA going out there, but you can pay somebody as little as $10, $20. Please go to my family home. I understand the grass lawn is long. Tell them I've sent you and go ahead and trim the grass lawn. You've done a lot. We're going to discuss malaria and how this grass lawn affects, causes mosquitoes to breed. You're doing something. You're hiring somebody. You cannot be there. Hire somebody. Hire somebody to take care of them. It could be a family member. Remember, we are all nurses. So the family member with the CNA in them and the heart to do that work. Because they're taking care of somebody, and they still have their own family members to be catered for. By the time you talk to them well and say, Auntie, I know you're my auntie, and I know you would at any time do this for free. But because you have a family depending on you, please take this token. Let it support the family while you're taking care of grandma, uncle, auntie, our niece, whom we cannot come to take care of because of distance or we cannot get leave away from work. There is a CNA in each and every one of us. There is a licensed practical nurse, a registered nurse, a charge nurse, an APRN, a DON, and a CNO. If somebody can coordinate all this care, even in matters extended family, that is the CNO who knows that in this family we have our niece who will be going this week. And from the other family, we have niece B who will be relieving niece A. And so our sick relative is being cared for. Now, the word never lies. When Jesus says go and do likewise, he really meant go and do likewise. And there's no way we can be told to do something that we have not been equipped to do. So let's use whatever little that we can do. Whatever little. Show up and clean the house. Show up and do the dishes. Show up with milk and bread. Show up with juice. Show up with fruits. Show up and say today, just prepare the food. I am feeding. In times of feeding, instead of sitting at the dining table, sit with the sick person. As they are being fed, eat your own. As they are eating, eat your own. You have done so much. We are so stretched of time. Pardon me, but that culminates the entire nursing hierarchy. And I'm so sure you've understood. If not, kindly watch the episode again. Understand. If you have a question, if you have a suggestion, if you have an input, drop it down in the comment box and let us all learn together. It's been me, Ludia Osita. I will see you in our next episode with a fresh topic, matters nursing as a ministry and as a profession. Until then, have a beautiful day. Goodbye.